Our next speaker is Dr. Prabhu Nesargikar, who is a senior consultant in GI and peritoneal cancer surgery, bariatric surgery, and advanced endoscopic surgery at HCG Hospital, Bengaluru. He is the clinical lead for Preventive Oncology at HCG and also is a HIPEC and PIPAC Surgery specialist for peritoneal cancers across HCG centers. He specializes in GI cancer, from organ-preserving endoscopic surgery to robotic surgery. He has done his basic and higher specialist surgical training from United Kingdom, and he has obtained his FRCS from the Royal College, Edinburgh. He also has a master's in medical education from Keele University and an MD in research from Cardiff University. After obtaining his CCT, he subsequently moved to Singapore and worked in National University Hospital as an associate consultant in GI surgery. During his stint in Singapore, he gained further specialist experience in gastric cancer surgery. At Seoul, South Korea, he has won many accolades, including the Young Investigator Award at ESOT Congress Belgium and fellowship awards at Japanese and Korean Gastric Cancer Congress. So we welcome Dr. Nesargikar to talk to us about topical hemostats, their types, and application in bloodless surgery. You're welcome, sir.
So thank you for the kind invite to the BMHS group. So it's nice to see all the familiar faces and be back. And I think there's more interest as well. I can see on the group. Today, my topic, which Nathaniel allocated, was topical hemostats, types and applications in bloodless surgery. That's my brief. So I've been in UK, Singapore, and now I'm settled in India, where I'm originally from. My spectrum of things goes from oncosurgery, predominantly gastrointestinal and peritoneal cancer, to bariatrics and then complex abdominal hernia surgery and endoscopic surgery. Who are we? So if you don't know HCG Hospital, we are a 26 cancer center chain across India, and also branches in Vietnam and also in Africa. So we are predominantly a cancer specialist hospital, so we don't do trauma emergencies or many benign network as it is. So this is my standard slide I put for all my talks for BMSS. So as you all are aware, for people who are joining in, students and other doctors, so BMSS is the provision of quality surgical care without the use of allogenic blood. This BMS is tailored to individual patient, incorporating a MDT approach. The main idea is to achieve excellent clinical outcomes while maintaining patient rights. We all know the adverse effects of blood transfusion is well known in critical care, general surgery, and now it's gaining prominence even in cancer surgery. So as you can see, there's a new recently systematic review which about blood transfusion, which showed that actually it not only increases post-op complications, but also increases your cancer recurrence rate. So nowadays when we operate on hemoglobin of 9 or 10, and we just maintain that throughout our surgery and post-operative period. So again, I'm just giving a brief background about the BMS's work we are trying to do as well. So as you all know, these are the 4 pillars of bloodless medicine surgery. 1 is optimizing the hematocrit. 2 is minimizing blood loss, where we as surgeons usually come in more often. 3 is optimizing tissue oxygenation. And 4 is lowering the transfusion trigger. So as you all are aware, minimizing blood loss just not starts in theater, but preoperative with the anesthetic planning. You all know the trauma triad of death, which is very important. How the blood loss increases if you have coagulopathy and temperature problems. Similarly, so where we come in is more on the intraoperative techniques as minimizing blood loss. So hopefully some people can take some message from what we're trying to say. Obviously, these are the 4 things I'm going to talk about briefly. Obviously, the 4th one being the topical hemostat, which is the subject of topic. Briefly about the lab surgeries, the energy devices, and the length of surgery, which all have been shown to increase blood loss. So before we're starting about topical hemostats, we just have to aim to say how we can reduce blood loss in surgery. So now the evidence is overwhelming. So any surgery, either laparoscopic or robotic, has been shown universally to lead to decreased intraoperative blood loss compared to open surgery, and then decreases the need for blood transfusion. So this is already proved in colon cancers, gastric cancers, and now even coming into HPV cancers. The next thing which we usually employ is the energy devices in our surgical technique. So from the olden days of just knife and sutures, now we have gone to radio frequency, bipolar, monopolar, and now we're using harmonics, ligashores, or thunder beats. They're all ultrasonic devices which help in reducing the blood loss, makes the surgery much more quicker. So the main idea for all these two techniques is to reduce the length of surgery, because we all know that any increased length of surgery is directly related to the increased blood loss and fluid shifts. It also affects the surgical fatigue and decision making and post-operative recovery. So the building up to the topical hemostat, the main idea is to suggest that whenever surgery is considered, lap robotic approach, reducing length of surgery, having dedicated teams actually minimizes the blood loss of your surgery. And basically meaning that you just have to reduce the need for topical hemostats if you do all the right things. So as you can see, the techniques of maintaining hemostats in surgery, there are the mechanical techniques. I'm not sure how many surgeons are on the talk today. These are the usual things we do: pressure, sutures, staples, ligating clips, gauzes and sponge, which are the usual ones. Thermal techniques, which briefly spoke about. The chemical techniques, the pharmacotherapy are there, but obviously with GOS witness patients, you should be considerate of what to use and what not to use. And the last thing is the topical hemostats, which I'm going to briefly talk about, because this is one of the things we sort of not very oftenly use, but it does help in your major cancer surgeries as such. So as you may all be aware, topical hemostat, I have to give due credit to the SABM group. There is a very good PDF file about topical hemostats on their website. So some of them has been inspired by that in a couple of more papers. So just before you understand about the topical hemostat, just back to basics, going back to medical school. So why does bleeding happen? So if you have vessel injury, how does your body react? The first is the vasoconstriction. Your blood vessel shrinks to reduce the blood flow. Then you have a platelet plug, and then you have a fibrin formation. So the primary hemostasis is what we call. So whenever we have a bleeding, the platelet plug comes and it forms a soft platelet plug, and that actually reduces your bleeding. The secondary hemostasis is where the fibrin mechanism kicks in. You have a strong fibrin clot, and these all lead to the stable hemostatic clot. So all hemostats are trying to achieve, or any technique is trying to achieve, is to form a clot and reduce your bleeding thing. This is again the coagulation cascade, which you all will learn in the maybe first year of medical school. The intrinsic pathway, the extrinsic pathway. And the whole idea is the whole coagulation cascade leads to the bottom, where the fibrinogen converts to fibrin, and that stabilizes in the fibrin clot mechanism. So coming to the classification of topical hemostats. So how do we classify the topical hemostats we use? One is the mechanism of action. There are factor concentrators, procoagulants, and mucoadhesive agents, or by the material sources. So those are the 4 listed types that we know of. But I want a surgeon to keep simple. So either they're called passive hemostatics or active hemostatics. So I'll briefly go through these quickly. This again, I had to research myself when I was doing this paper. So mechanism of action, there are 3 basic types. The factor concentrator means it's a water absorbing substance. It basically thickens the blood, activates the coagulation factor. The procoagulants, as you know, in the intrinsic pathway and the extrinsic pathway kick in and stop it. And the mucoadhesive agents like the gel and the glue which we use, which all 3 contribute as a topical hemostat mechanism. Now, this is a long list of material sources. Again, the references at the end. So basically, they say there are 4 basic types. One is the inorganic-based hemostatic materials, plenty of the granules and the commercial products as listed. The polysaccharides one, again, we don't use this much, but again, the starch and the cellulose components, we use it routinely. Surges as one of the most commonest used worldwide. Coming to the biologically derived homeostatic materials, they are the thrombin-based and the fibrinogen-based. Again, the more common ones are the tissues, the ebicels, which people may be used to, or the Surgiflow and the gel forms. And the last one is the synthetic derived hemostatic materials. Again, a long list, but I'm just going to keep it simple because we as surgeons or as practicing doctors, main thing is whether it is passive or active. So what does a passive hemostatic agent mean? So basically, this is the coagulation pathway you can all see. So obviously, the whole aim is even if you have a normal cut on your body now, eventually you will have a clot form because you have a normal clotting mechanism. So when we do surgeries, most of our patients do have normal coagulation cascade, apart from when you're doing liver transplants or patients in trauma where your coagulation cascade is not intact. So the passive hemostatic agents, there's a simple thing. If it's a minor ruse, like a collagen-based, it just provides mechanical hemostasis by scaffolding and platelet activation. But for this to work, the coagulation cascade should be intact because it works quite high above on the action mechanism. And this is usually used for minor bleeding or oozing. And now these are the popular passive hemostatic agents, which is used, I think, commercially worldwide. The gel foam and the Surgi foam is very commonly used, as I said, and the oxidized cellulose mechanism, the Surgicel. So both of these basically, as passive hemostat is a minor ooze, you place them on it, it absorbs water, it thickens the blood and stops the minor ooze. Now, as I said, gel foam, one of the commonest ones. I'm just going to talk about a couple of the topical hemostats. So how does the gel foam act? As you can see, this is the foam. So if you have a bleeding on any of your vessel or a minor ooze, you just place a gel foam on it. It aggregates on hydration into larger particles. It causes a mechanical obstruction, slows the blood flow, and hastens the thrombus formation. Very simple to use. Similarly, the other commonest one is Surgicel, which is a very flexible gauze-like material. This basically contains the oxidized cellulose, again, which this absorbs blood and becomes a gel covering the site of vessel injury. Just used one now in my surgery. Now there's a bit of ooze. We just put a Surgicel because it was not able to be sutured or clipped. It creates a low pH, causing localized vasoconstriction, and also provides a matrix for the platelet addition, actually the formation of the platelet plug. Again, this is the foundation for the fibrin clot. Now, I don't know, some guys may be using as a passive hemostat. I've also bought in hemostat. I do endoscopies. So we do have GI bleeding. So olden days, when you have a GI bleed, it is difficult to control. We used to go with dry clipping or argon beam or any of those sorts. But this is one of the products which is now, it has been there for the last few years now. Hemospray is one of the topical things. So imagine if you have a bleeding on your duodenal ulcer, you go in, it is sort of massively squoozing around. You just use the spray thing through your endoscopy. You spray on the mucosa of your duodenum, and it magically works. It has worked for us plenty of times, slightly expensive than the clips though. But in this one, it's a topical hemostat we use specifically in endoscopies. So again, this works the same way. The moment there's a bleeding, you deploy the hemospray powder. It's like a pressurized chamber. You just spray over the ulcer. It absorbs water, again, forms a barrier, and then the bleeding stops. This can be reused as well. So nowadays in emergency, when the expertise is not available across the world, this is one of the topical hemostats. They're sort of doing it in endoscopic practice. Now, coming to the active hemostatic agents, so what I thought was the passive one. So the passive, as I said, you need to have an intact coagulation cascade. The active hemostatic agents, on the other hand, they can be used when even your coagulation cascade are not very well. So example, if you're a chronic liver disease patient, trauma patient, these are some things you might try to use more often. So how does an active hemostat work? It basically is a biologically active substance that participates in the blood coagulation cascade, as you can see on the right diaphragm. So the fibrinogen, actins, the thrombin, these are all commercially made. So these active agents participate or accelerate your coagulation cascade. So they directly catalyze the activation. They bring the platelets to the adhesion site, helps in the formation of the clot. They also directly stimulate the conversion of fibrinogen into fibrin. And this initiates a strong fibrin clot formation at the bleeding site. So these are some of the active hemostatic agents in literature use. So there is a thrombin-based one. There is one on the bovine and the human plasma-based. The thrombin is a mechanical agent, which is the flow seal in the Surgi flow. Again, very commonly used in surgical practice worldwide. And the last is the fibrin sealant, which has a thrombin and fibrinogen complex, the T cells and the AV cells. So briefly, I'm just going to talk about the three active hemostats, which are more commonly used. This is the Tacocell. So Tacocell comes with preformed human thrombin. So it's got a sealer protein in the thrombin. It comes as a dual mechanism. There are two syringes loaded up. So when it's about to be, when you need to deploy it, you basically have to load the syringes, mix it in. And what does it do? Basically, when mixing the two primer, which is the protein and the thrombin, soluble fibrinogen is transformed to fibrin. So that forms a net-like matrix and firmly adheres to the exposed collagen. So this achieves hemostasis or even gluing of tissues. So some people, when they do hernia repairs nowadays, before they're putting a tack or a stapler, they actually use Tacocell. And they put the mesh on top of the hernia and actually sticks. So again, Tacocell is one of the active hemostats we're using. The other one, which is very commonly used, is a flow seal. So flow seal is similar. Only thing you need to make sure that you've got a very good nurse in your OT room who knows how to mix the flow seal. So there are actually two tubes. It comes in a separate pack. Again, it is a mixture of a gelatin matrix and thrombin solution. You put it up, you mix the solution each other. Once it's constituted, you can use up to 4 to 6 hours, but it has to be done very carefully and in a good manner so that the liquid nature of it is maintained. So how does the flow seal work? Imagine you have a crater or something, there's a bleed on your retroperitoneal area. Then what you do is you do the flow seal and just deploy on that. It takes a granule shape. It actually takes even the cavity of the wound. The granules swell up within 10 to 20 minutes when you deploy the flow seal. High concentration of thrombin causes the rapid formation of the reinforced clot. And once it is done, as I said, it just gets gradually reabsorbed over a duration of time, and very active, very good for pelvic bleeds. The other one, which is the Tacocell. The Tacocell we used to use very common in our transplant patients when we're doing HPB surgeries. This is a combination of a human fibrinogen, human thrombin, but on an equine collagen sponge. So the yellow is the active side. Now they're using Tacocells in neurosurgery. There is a gap in your dura. They tend to use it for the repair of the dura as well. So this is one I've not commonly come across, but still in the literature is the Ricotrom, which is a thrombin-based topical hemostat. Again, it activates directly the platelets, and again, conversion of fibrin into fibrin. So all of these hemostats are trying to come together to form the final steps, because you need fibrin to form the clot. There's no clot, it will still continue to bleed, but it's slightly on the pricier side. So the last component of the topical is the surgical sealants and glue. Now, this is a Nature Review paper. As you can see, it started in 1940s, and still there are plenty of commercial products up to 2017. The main thing we talk about surgical sealant and glue, again, it depends on your specialty, where you use it. I use glue maybe in bariatric surgery, on your staple lines occasionally. But this is one of the things we again have it in an armamentarium. So the last bit of the talks is topical hemostats, how to use when and while. As I said, it's not a substitute for good surgical technique, but you should know which hemostat to use when. Now, when I researched about this thing, obviously, this is a very popular paper by Bracey and Chandra et al., published 2017. And they tried to do a flow drawing of to say when you can use topical hemostat in cardiovascular surgery. So I'm not a cardiac surgeon per se, but what they're trying to showcase in a literature review is if you have a coagulation intact, yes or no. If you have a yes, you are a normal coagulopathy patient. You have a bleeding which sees your high risk of bleeding, you can use albumin or PEG polymers. If the bleeding starts, you can use mechanical agents or surgical repair. But when their cardiac status, they usually used to get patients because people go on the bypass, they use heparin. So they have a coagulation status which is not pretty much intact when the time of surgery. So they devised 3 scenarios: the mild focal, the moderate severe focal, and the diffuse bleeding type. And you can see they sort of recommended if you have a minor ooze, just use the thrombin or the recombinant thrombin products. If you have a moderate to severe flow, you can use the flowable agents like the Surgiseal. And the last is seal it for diffuse bleeding. So coming to my practice, obviously, to highlight what we use for our topical hemostats. As I said, most of our patients, the whole aim is to minimize bleeding from day one. Hemostat is only an adjunct to good surgical technique. So in our case, we try to do pre-optimize everyone. So the anemia is optimized pre-operatively. The clotting parameters are looked into. We do use the embolization. So if you have complex retroperitoneal tumors, pelvic tumors, we prefer to embolize them pre-operatively a day before. So that decreases the bleeding intraoperatively. Because I'm a GI cancer specialist, we always do radiation therapy, especially for esophagus and rectum, and that actually reduces bleeding as well. And if you're doing any surgeries on alcoholic liver disease or chronic liver disease patient, ensure you get a good input from your hepatologist for liver optimization. As I said, basically optimizing all you can do to do that. So in my practice, all patients of GI cancers or peritoneal cancers go through pre-op optimization and prehabilitation, embolization, as I mentioned about. So all our patients are default laparoscopic or robotic approach as a standard setup. Only if I do a CRS or HIPEC surgery, they go for open surgeries. Again, this is again in the second pillar to minimize your blood loss. We have ligation or harmonic and cautery as a standard. It may be luxury for us, but may not be available worldwide. But if we can get holds on them, they actually accelerate surgery and reduce the blood loss. All our major blood vessels are ligated with hemolocks and ligatures. We all have VRAS protocol. As I said, our transfusion rates are less than 5%. In India, in our practice, obviously, there's not much GWAS weakness as such, but we are trying to practice bloodless medicine. Our baseline hemoglobin for all of our patients are 10. We go for surgery on 10. They go home on hemoglobin of 9, and they have no issues with that at all. Coming to topical hemostats, I use in less than 10% of our cases. Very rarely we use it because mainly in most GI cancers, the esophagectomies, the gastrectomies, the suture and the cautery and the pressure usually works. When it does not work, then these are 3 things we have used often. So Surgicel, so people, if you did a cholecystectomy, the gallbladder bed is oozing in spite of cautery and the pressure, Surgicel works very well. Splenic surface injuries when you're doing your splenic flexion mobilizations, pancreatic surface ooze, lymphadenectomy around major structures. So if you have doing esophagectomy around my trachea or the subcanal area, I don't want to take diathermy anywhere towards the airway pipes. And there, Surgicel is very good. So if there's a bite of ooze from your lymphadenectomy site, pop a Surgicel, it just settles it off. So Surgicel, passive hemostat, works wonderfully in most of the cases. The FlowSeal, which is an active hemostat, as I said, if you're doing a complex pelvic surgery, pelvic accentration surgery, there's a pelvic bleed, FlowSeal works better than a Surgicel because it actually accelerates and complements your coagulation cascade. Similarly, in the retroperitoneal ooze as well, Tacocell we use in hepatectomy cases. There's a bleed, put a Tacocell, leave it alone, the bleeding stops. Again, in spleen surface surgery or renal surgery. Glue, rarely used, as I said, so we use it only for our sleeve gastrectomies or staple lines. And now glue is also being used for lung surface. So you have an air leak, we're doing esophagectomy, there's a ruptured bulla, we just spray the glue, we don't go to suture anymore. So all those kind of things go and stick it up. Main thing also, you should be aware of cautions. Again, this is a slide taken from the SABM presentation. Please, if you're doing it in especially GHOS patients, do check with your patients which is safely acceptable, not acceptable, because there are human thrombin derivatives, there are animal thrombin derivatives. So that's very important to know. So please refer to SABM website for further details. Again, from them, so again, be cautious. There are many which are from animal origin. So if you have something from a beef or a pork, you can, so your Muslim patients may not want to be used. So be careful about which is the origin of the source before you use it. So in any major cancer patients, we always try to see if they have allergy to any, avoid any derivatives which they don't want to. Main thing is cautions. Main thing you need to understand, hemostats are not intended as a substitute for a sound surgical technique, and proper application of ligatures or other conventional procedures for hemostasis is important. Main thing with any FlowSeals or any the thrombin products, do not inject or place into blood vessels, and do not aspirate directly into cell saver devices. So if you're using a cell saver, I would say don't use any of the active hemostats because that will go and clog up the system and the cell saver becomes a bit redundant from that point of view. So if you're wanting to use, you just use a passive hemostat like a gel form or a Surgicel, but not the active hemostat. Now, future perspectives, there is plenty of research evidence going along as to what they could do. So there are a couple of papers I've had at the end. Now, this is all studies happening in animal models where they're making bleeding on the liver and they're not even suturing it. They're just placing the hemostat on it and that all stops bleeding. I've just used a couple of examples. On the right, you can see the amount of trials that are being used at the moment across the world in all specialty of surgery, from orthopedics to general surgery to neurosurgery, all trying to see if they can use more hemostatic products. Because the moment there's a bit of a blood loss, it increases your length of surgery, the vision becomes very poor. So all are trying to see if we can reduce the blood loss the moment it starts. So that is the main thing. So to conclude, topical hemostats are useful adjuncts for hemostasis in surgery. But for me, the main thing is please plan your surgery, surgical planning, and intraoperative anticipation. It's the most important thing because that reduces your bleeding risks. Beware of bleeding close to airways. So especially anything in your airway pipe, thoracic surgery, please don't use diathermy because the tracheal injury is very unforgiving. And also be closure of diathermy in your veins and blood vessels. Choose the right topical hemostat for the right occasion. That's why it's very important to know what is a passive, what is an active, which do you use when. Because if you use in the right way, it's just going to help, it's going to work. And know the product details before use. You don't want to end up in a medical legal case to say you used a pork-based hemostat on a patient, they'll catch you out for that. These are my references. As I said, they're good reading on the SABM website, a couple of papers which I highlighted. Thank you.